Dear colleagues, welcome to my hospital at Ranaghat, West Bengal, India. This patient is on Tamsulosin for treatment of benign prostatic hyperplasia. I am expecting floppy iris in this case. Let us see what happened and how I managed the case. By this time the main incision has been placed at a selected site. Now 2% hydroxypropyl methyl cellulose is being injected into the anterior chamber. The patient is under topical anesthesia and I am struggling to keep focus. The centration is getting disturbed very frequently. It happens in topical Phaco. For the first 2-3 minutes, the patient moves his or her eyes a lot. Gradually they get adjusted to the light and they can cooperate better after 2-3 minutes. So if you find that the patient is moving his or her eyes a lot, don't get scared. The patient will be able to cooperate within a few minutes. I never use intracameral agents like preservative-free xylocaine. I just do it with surface anesthesia with proparacaine eye drops. Now, hydrodissection. I have done capsulorhexis with a 26 case needle in this case because I didn't get enough space to go through the main side port. The patient was moving a lot and it was easier for me to do rhexis through the side port with a needle. So hydrodissection has been done and now is the main challenge. I am expecting floppy iris in this case. Let us see what happens. The Phaco handpiece is introduced into the antechamber. Some superficial cortical matter is removed. Now the Phaco handpiece is turned. The bevel is turned towards the corneal endothelium. Now I introduce the chopper and as soon as I try to do direct chop, see what happens. The iris tends to prolapse through the side port. This is very typical of floppy iris. If the side port is little bigger, it can come out through the side port. In this case, I opted to continue with chopping and emulsifying. The cataract was not hard, it was quite soft and I could chop it and emulsify it very easily. Now I am trying to remove the epinucleus and this is very dangerous. We must not use any power. We must be very gentle, very cautious. The chamber should not be collapsing at any moment. Just have to hold the edge of the epinucleus, pull it at the center and then apply very minimal energy, say only 10% ultrasonic energy to emulsify the epinucleus and remove it. We may not use Phaco energy at all. Yes, the epinucleus has been removed. Now, first remove the Phaco handpiece and then let the chamber be shallow. Let the iris retract and then remove the chopper. Otherwise, you can injure the iris. Yes, whenever the iris is incarcerated in the wound, always remove the Phaco handpiece first. Let the chamber be shallow a bit and let the iris go into the anterior chamber and then remove the chopper. And now the cortical matter is being removed. with the Simcoe. If we use bimanual, it is okay, but again, if we use bimanual, the iris will tend to prolapse through the side ports. But with Simcoe, we can control that. We can keep the aspiration more than irrigation with Simcoe. We get more control and we can prevent prolapse of iris through the side ports. The patient could not cooperate well, frequently keeping the other eye closed in spite of repeated instructions. The eyeball is rolling upwards. But the patient is not complaining of any pain, although I am touching the iris. At the end, I asked whether the patient had experienced any pain or not, and he said no. So those of you who want to do phacoemulsification under topical anesthesia, just go ahead and practice with only surface anesthesia. No intracameral agent is necessary. I am doing topical Phaco for the last 10 years or even more, and I didn't use intracameral agent. I used in 2-3 cases only in these last 10 years. It doesn't help much, and it is not necessary at all. Just surface anesthesia with proparacaine eye drops is enough. In some cases, you may need soft tenon anesthesia as supplementary. Yes. Now I am injecting the lens under visco because visco has dilated the pupil a bit, and it will help me in visualizing the rhexis margin. The lens, the leading haptic, has gone into the capsular bag, and now the trailing haptic is going into the capsular bag. Dear colleagues, whenever you use viscoelastic substance for implantation of intraocular lens, please remove the viscoelastic substance thoroughly. If you don't use Simcoe, use bimanual irrigation aspiration for a longer time. But in floppy iris, this Simcoe is wonderful because you can suck more than your irrigation, and you can control the chamber much better. Yes, with proper setting, with bimanual also, with low bottle height, you can prevent iris prolapse. Now, after irrigating the anterior chamber for some time with the Simcoe and irrigation and aspiration for some more time, and removing lot of viscoelastic substance, my aim is to have a quiet anterior chamber next day to see the normal, happy face of the patient. The patient should not be complaining of any pain or any discomfort in the night. And now I take the bimanual irrigation aspiration and use the bimanual IA for some time. Here I have kept the bottle height little low so that the irrigation is more. Still you can see that the iris is tending to prolapse, tending to get incarcerated in the side ports. You can see the oblong iris because of its tendency to prolapse through the side ports. Yes, the visco has been cleaned out very nicely. Now, to buy some time, because the anterior chamber is getting shallow, inject air, and then I inject some antibiotic. This is moxifloxacin, and then I hydrate the stroma on either side of the paracentesis openings, and the paracentesis closes nicely if we hydrate the stroma. These stab wounds become watertight. And now is the time to do the final lavage of the anterior chamber. Yes, this is my routine practice. I always do this final lavage of the anterior chamber with balanced salt solution. You can use PSS of any good company and do this lavage, and you will never see TAS next day if it is a good quality sterile BSS. And now the antechamber is formed nicely. There should not be any leakage from any wound. The antechamber is formed nicely and the case is concluded. Let these two air bubbles be there in the anterior chamber. Thank you very much for watching. Hope this video will help you in managing floppy iris cases without using pupil expansion devices. Be better and do better.